on a note of innovation, we are going to be treated next to an interview with Dr. Benjamin Warf, who has been using one of the technologies that HITLAB has been working very closely with over the last couple of months, called TeleVU. And TeleVU is an organization that has a set of different solutions within its suite that enable remote medical assistance for physicians through audio and video communication, AR and AI, to effectively enhance and help clinicians and health organizations deliver the best care to patients in a remote fashion. So Dr. Benjamin Warf is one of these physicians that has been recently using this solution, and we're going to hear from him and Stan. I know everyone's been wondering where Stan is, and we will actually get to hear him today at this summit, albeit in a recorded format. But this is when Stan met Dr. Benjamin Warf to talk about his use of TeleVU.
It's my pleasure now to introduce Dr. Warf, Dr. Benjamin Warf, who is a world-renowned physician and surgeon. And we're going to talk to him a little bit today about his experience with TeleVU and what he's been doing with this new emerging technology that really is helping improve access and quality of medicine globally. And Dr. Warf, thank you for joining us today. First of all, and second of all, if you could please give us a little bit of your background and what you do.
Well, sure. I'm currently a professor of neurosurgery at Harvard Medical School, and I am a pediatric neurosurgeon. I work at Boston Children's Hospital, where I'm the director of neonatal and congenital anomalies neurosurgery. Also, I've had a long standing involvement with global neurosurgery that goes back to before 2000. In 2000, my family and I moved to Uganda and lived there for about 6.5 years to help start a neurosurgery hospital for children. And during the years that we were there, two significant things happened. One was we found that there was an enormous volume of hydrocephalus in babies there, most of which was secondary to neonatal infection, and that's something that hadn't really been appreciated before. The second thing that we accomplished there was, most infant hydrocephalus has been and is treated with shunt placement, ventriculoperitoneal shunt that drains fluid from the brain into the abdominal cavity. It's been the standard of care for half a century now. But shunts fail. About half of them will fail in less than 5 years. They tend to fail multiple times over the years. It's a lifelong risk. And treating hydrocephalus in babies in low and middle income countries with shunts is very problematic because when the shunts fail, and especially when the children are a little older later in life and their skulls are solid, it's a medical emergency. And if you don't revise the shunt, it can be, and typically would be, fatal. So if children are shunt dependent and don't have ready access to emergency neurosurgical care to fix the shunt, that's a big problem. And we were replacing the problem of hydrocephalus with the problem of shunt dependence. So we developed a new procedure there that combined two procedures. One was endoscopic third ventriculostomy, and then we combined that with something called choroid plexus cauterization. And we found that when we combined those two together, which hadn't been done before, we had a very good success rate. For instance, in children with hydrocephalus that was associated with spina bifida, we could treat their hydrocephalus successfully 75% of the time long-term without the need for a shunt. Overall, about 2/3 of the children can be treated successfully this way. So being free from shunt dependence for the rest of their life was a very important thing in the context of a developing country. Fast forward 20 years now, and we have started an organization called NeuroKids. We just launched the organization last year. And what we do is train and equip neurosurgeons in developing countries to use this technique so that they can treat hydrocephalus without the need for a shunt in the majority of their patients. And part of this program involves there's a pre-site visit curriculum, which involves Zoom calls and online curriculum and reading and videos. Then we do a site visit where we, myself or one of my neurosurgery colleagues that's involved in this with me now, operate with the neurosurgeon in their home hospital on their own patient population. We're doing about 10 of these cases in a week and a half. And then we follow that up with post-site visit remote presence mentoring. And this is using TeleVU, and it works something like this. The surgeon is wearing glasses called Vuzix glasses, where I can see in one screen of my computer, I can see everything they're looking at in real time. They can hear me, I can hear them, and they can see me in a little heads-up display in the glasses. The other screen that I'm looking at with the TeleVU system is their video monitor, which is looking at which is connected to the endoscope. So I'm looking in real time while they are driving the endoscope around in the ventricles of the brain. And I can telestrate and point to things and talk to them. And this is proving very helpful in continuing to train and mentor them to help build their confidence and improve their abilities. And this is kind of a new paradigm. For years, up until a couple of years ago, what we were involved in doing was bringing surgeons to a site in Africa, actually that hospital that I went to help start in Uganda, having them stay there for 2 or 3 months and do the training away from their work, away from their families, and then going back home to a different environment to do the treatment. So now we allow them to stay where they are. They don't have to travel. And we train them in their own environment, on their own patient population. And we can continue this process of mentoring and training them through virtual presence technology. And that's where the TeleVU comes in.
In your experience with TeleVU, how long did it take you to implement the technology and to be trained on the platform before you could start using it?
Well, it's from my end, it's really very user friendly. It didn't take long at all. One of the TeleVU technical assistant folks just got online with me, walked me through it, and it's very straightforward. So I would say I had fairly mastered what I needed to know in about 30 minutes. The more challenging parts are getting the technology set up in the on-site in the trainees' operating room and making sure that they have an adequate internet connection. But so far, we've been able to do this, and in fact, as soon as we get off of this interview we're recording right now, I'm joining an operation in Luanda in Angola, where the connection is great. We tested it out earlier this week, and this will be the first actual operation I will be helping this neurosurgeon with in Angola.
That's brilliant. So you'd say it took you kind of 5 to 10 hours to learn and implement the TeleVU system, or 10 to 20, more than 20 hours? How long would you say overall it took you to learn the TeleVU system?
30 minutes. It's just, that's not not hours. I mean, it's it's the heavy lifting really is with getting the equipment to the surgeon's operating room, helping them get it set up, which the TeleVU people do. But it's pretty straightforward, really. And so it literally took me about 30 minutes to learn how to learn how to use it and to telestrate on the on the surgeon's screen and so forth. It's very straightforward. So it sounds and is a very interesting and helpful piece of technology, but in terms of how difficult it is to use, not very straightforward. And once you sort of get into it, it's just like being in the operating room with the surgeon. It's very realistic. It's just like me standing in the operating room, because when I'm training someone using these endoscopic procedures, I don't have my hands in there with them. I'm basically standing there watching them do this. It's a one-person thing, and I'll walk over to the screen and point to things and say, go here, don't go there, don't do that. I can do all that from 5,000 miles away as well as I can standing in the room with them. The only thing I can't do is take the scope out of their hands and finish it for them. So yeah, it works. It's been really helpful, and I think going forward, it's going to be a centerpiece of what we're able to do.
That's fantastic. And when you look at this technology and you look at how it's being used by yourself and your team with people in Uganda, what are the economic benefits that you could see this deriving? How could a hospital surgeon, how could a surgeon anywhere in the world and others derive economic benefits from this as a way to sustain and scale it as it grows?
Well, my goodness, if I were to do this in person, it involves flying to the hospital, flying to the other country, staying there, and being away from my own practice and family. And I can only do that for a limited period of time. But that's, doing that for a week is quite expensive. And so being able to do this instead of making repeated trips back, I can do this from my office or my laptop at home, and I have done both. So it's very cost efficient. It saves us a lot of money and time and trouble. And as much as I travel, I really hate flying. So there's that too. It's great.
That's really good to hear. And in terms of optimizing and enhancing the revenue of your unit and your department, how is it generating new revenues for your department so that it can be something that's more scalable internally?
Well, now that's a question that I haven't really thought about very much, because we're our program, our nonprofit NeuroKids is just that. It's a nonprofit, and so we're doing this to help children at the end of the day, to help children in low income countries. So we're not gaining any revenue from it, but we're certainly putting to much better use the funds that we get from donors and foundations and grants. So money that would otherwise be spent on travel, that's eliminated, except for the one-time site visit. So we're able to better use donor funding.
That's fantastic. So that's a great economic benefit, certainly right there. And from what you've seen, and I know you've been using it for a short period of time,
yeah.
What have some of the improved clinical outcomes looked like for you?
Well, I'll give you an example. And as you've already said, we're a little early into this and haven't had as much experience as it'd be nice to do this interview a year from now, frankly. But One example is I was one of the surgeons that I had personally gone to train in Cairo, in Egypt. He was doing one of these procedures on a child with hydrocephalus secondary to the child's having had spina bifida. And those children have they can have very complex anatomy within the ventricles of the brain, abnormal anatomy from something called the Chiari malformation. So those cases tend to be more daunting to the relatively inexperienced neuroendoscopist because of the variations in anatomy. So I was able to, with him, look in the ventricle, figure out the anatomy, helped him with that. And together we selected the site to make the opening, which is the ETV opening in the floor of the third ventricle, and navigated some pretty complex anatomy that I think without my help would have been more difficult for him. And there are risks to this, and so it hopefully avoided any risk of a child's life or function by having a more experienced eye to go over this complex anatomy with him.
I think that's certainly good to know, and it's certainly important as we're seeing technologies like this, and certainly TeleVU really enhance the patient experience globally. Those are important elements to understand and really appreciate it. And we will schedule a follow-up interview for a year from today. So look for an invite on your calendar, and again, more feedback on digital health outcomes for our audiences around the world. And thank you very much, Dr. Warf, for joining us today. And we know you have to run off to a surgery now using TeleVU. So
I do, yes.
So have a terrific surgery. Have a terrific day, and thank you for your time.